Hey everyone, welcome back to our 100-part CPC exam series. I am so pumped you're here for part 39 because today we're unlocking the Pathology and Laboratory CPT section. This explainer is going to hand you the exact strategies you need to absolutely master this highly specific domain. Oh, and right off the bat, make sure to like, share, and subscribe to Decode Healthcare with Harshal so you never miss an update.
Okay, let's dive into this. We've got a clear, actionable syllabus today to lower your cognitive load. First, a quick path and lab overview. Second, the crucial rule of panels. Third, presumptive versus definitive tests. And finally, surgical pathology levels.
All right, kicking things off with Section 1, Path and Lab Overview. So on the 2026 CPC exam, this section makes up about 4% of your questions. But hey, do not let that small number fool you. These questions are rigorous rule triggers. We're talking about a scope spanning codes 80047 all the way through 89398. You're going to be coding everything from high-volume, routine stuff like a basic metabolic panel all the way up to high-risk complexities like next-generation genomic sequencing. It's a massive spectrum.
Moving right along to Section 2, the rule of panels.
Found in the 847 to 881 code range, organ or disease-oriented panels are, frankly, a massive exam trap. Here is your absolute unbreakable rule. All listed components of a panel must be performed to report that panel code, no exceptions. If even a single test in that panel's descriptor is omitted, the panel code is completely invalid. You basically can't code an almost complete panel. Instead, you've got to unbundle the whole thing and report each performed test individually.
So the crucial point is this. When a patient has multiple panels ordered, never, ever report two panels that contain overlapping individual tests. If you see an overlap, you need to code the primary, most comprehensive panel and then just individually report the non-overlapping extras. Basically, do not double bill an analyte. The examiners will definitely try to catch you on that.
Now we're shifting gears into Section 3, presumptive versus definitive tests.
When you're looking at clinical drug testing in microbiology, the exam will heavily test your ability to differentiate the exact testing methodology used, and this brilliantly illustrates that contrast. For instance, presumptive drug screening, that's codes 80305 to 80307, well, that's qualitative. It literally just identifies the presence or absence of a drug class. It's just a screen. On the flip side, definitive testing, think mass spectrometry in the 80320 to 80377 range, is quantitative. It actually measures the specific concentration or identifies a specific metabolite. Screen versus quantify. You've got to keep that binary in mind.
We actually see a very similar binary framing over in hematology. Take a look at the complete blood count, or CPC. Your code selection completely changes based on just one tiny detail. Did the lab run an automated differential white blood cell count or not? If they did, boom, it's 85025. If they ran it without the differential, it's 85027. You have to read those operative reports incredibly carefully.
And you know what? This exact same logic applies to microbiology too. A presumptive identification of an infectious agent is coded entirely differently from a definitive isolated culture test. Whether we're talking about blood, urine, stool, or throat specimens, the methodology is always what drives the code.
All right, let's move into our final major topic. Section 4, Surgical Pathology Levels.
Covering codes 88300 to 88309, I want you to think of this section as a leveling up game based strictly on tissue complexity. But before we level up, we absolutely have to define the concept of specimen. Listen closely. If a surgeon removes multiple distinct lesions, say 5 different skin punch biopsies, and submits them separately for individual pathologic evaluation, each distinct specimen gets its own separate pathology code. It's literally a one-to-one match.
Now, check out how we graduate through these 6 levels of complexity. Level I, code 88300, is for gross examination only, meaning no microscope is needed. From there, we scale up based on the tissue itself. Level 3 includes your straightforward skin biopsies. Level 4 covers routine gallbladder or appendix exams. And this scales all the way up to Level V, which represents highly complex radical tissue resections from malignant tumors. The golden rule here? You must match the code to the specific tissue type.
Let's move to and see how this builds with add-on procedures. Please, never assume that special stains or immunohistochemistry are just automatically included in a standard biopsy code. Spoiler alert, they aren't. Special stains like 88312
And immunohistochemistry, like 88341, are very specific add-on codes. If they're explicitly documented by the provider, they are separately reportable. Don't leave those codes on the table.
To wrap all these dense guidelines up, it's time for Section 5, the Part 39 cheat sheet.
Here are your rapid-fire golden rules for this explainer. 1. Panels are all or nothing. If you miss a test, you unbundle the whole thing. 2. Presumptive means qualitative screening. Definitive means quantitative measurement. 3. The specimen concept dictates separate codes for separate, distinct lesions. And 4. For surgical pathology, you have to directly match the CPT level to the specific tissue complexity documented. Lock these in.
So what does this all mean for you? Well, how confident are you feeling about path and lab codes now? You've got the rules down for sure, but the challenge doesn't stop here. Are you ready for the medicine section? In Part 40, we're doing a massive deep dive into immunizations, cardiology, and non-invasive vascular studies. It's a really rule-heavy section you absolutely won't want to miss. Keep studying, keep practicing, and I will see you in Part 40.